Jones tubes are used to correct canalicular failure by creating a bypass channel for tear drainage. Typically, a Jones tube is used as a primary procedure with a DCR or a secondary procedure following a previous DCR. The placement of Jones tubes is known as conjunctivodacryocysto-rhinostomy or CDCR. Tubes have a high success rate and patient satisfaction rate. However, there is little to hold the tube in place, and the main complication is extrusion, typically caused by blowing one's nose, sneezing, coughing, or rubbing the eye. 50% of Jones tubes are lost within a few years. The StopLoss Jone tube is a Pyrex tube that comes in a full range of lengths and has the traditional external flange and has the addition of an internal silicone flange, which seems to prevent extrusion. The procedure begins with creating a fistula from the conjunctiva to the nasal cavity and then inserting the StopLoss Jone tube permanently to maintain the fistula and provide drainage. The StopLoss Jone tube system uses an individually packaged sterile sizing and insertion kit and the appropriate individually packaged sterile unique StopLoss Jone tube, Pyrex tube with silicone flange. Both have a shelf life of up to 5 years. The silicone flange is securely bonded to the glass 2 millimeters from the distal tip of the tube. There is also an individually packaged sterile single-use removal set available if needed. The tube comes in lengths of 9 to 22 millimeters in 1 millimeter increments. The external flange sizes are the standard 3.5 and 4 millimeter. The most common tube lengths are 17 and 18 millimeters, but a typical range to have on hand is 13 to 21. Using the sizing and insertion kit, the surgeon will determine the appropriate size of the StopLoss Jone tube. This kit includes a guide wire with a sharp and a blunt end, a detachable button cap for the guide wire, a dilator with narrow and broad ends, and 4 dummy sizer tubes. The 4 sizers include lengths of 15 and 20 millimeters each at external flange diameters of 3.5 and 4 millimeters. Each have 5 rings at 1 millimeter increments from the internal distal tip. Proper sizing and positioning are crucial to surgical success. Success depends on external flange position, tube length, internal flange position, and internal tube opening. Step 1. Place the button cap on the blunt end of the guide wire. Step 2 and 3. Use the sharp end of the guide wire to create the required track between the inner corner of the eye, also known as the caruncle, and the nose. In general, the guide wire passes in the plane of the iris. Aim for the wire to pass through the lacrimal sac just below the opening of the common canaliculus just before reaching the septum. Step 4. Remove the button cap, leaving the guide wire in place. Step 5 and 6. Use the narrow end of the dilator to enlarge the track by passing it down the guide wire to the nose. Steps 7 and 8. Keep the guide wire in place, remove the dilator, reverse it, and use the broad end of the dilator to widen the track. Keep the guide wire in place and remove the dilator. Steps 9 and 10. Pass a 4 millimeter external flange dummy tube down the guide wire so the flange is placed at the caruncle and the inner distal end of the dummy tube enters the nose. If necessary, use a dummy tube with a smaller external flange diameter for the correct fit at the caruncle. If required, use a sizing device with a different length to ensure the inner end reaches the nose. Step 11. Remove the guide wire and view inside the nose. In order to calculate the optimal tube length, this calculation should be followed. Take the known dummy tube length that was used, either 15 or 20 millimeters, deduct the number of rings visible in the nose. Note that the dummy tube length minus the number of rings visible in the nose equals the length of the tissue tract. Then always add back 4. Why? This will be 4 millimeters longer than the tissue tract to account for a necessary 2 millimeter distance from the lateral nasal wall to the internal silicone flange, and the 2 millimeter fixed distance from the silicone flange to the tip of the tube. For example, assume we used the 20 millimeter length dummy tube, and we can see 3 rings visible in the nose. Subtract the 3 rings, 3, from 20, the length of the tube, and add back 4. 20 minus 3 equals 17, plus 4 equals 21. The patient will require a 21 millimeter StopLoss Jones tube. The consequence of not following the necessary formula to calculate the appropriate length will position the internal flange either too close to the lateral nasal wall or the tip of the tube too close to the septum. Step 12. Replace the guide wire and remove the sizing device. Step 13 and 14. Open the sterile, appropriate size, diameter and length StopLoss Jones tube and pass it down the guide wire so that the silicone flange opens fully when in the nose. Step 15. Remove the guide wire. Verify placement of the tube visually through the nose, confirming that the flange is intact, in the correct position, 2 millimeters from the lateral nasal wall, and that the distal tip of the tube is not touching the septum. If necessary, secure the tube for 1 to 3 weeks with a suture passed around the neck of the external flange and attached to the skin. If it is necessary to remove any type of Jones tube, a surgeon can use an individually packaged, sterile, disposable removal tool. The removal tool set consists of a metal rod with a loop silk suture and a guide wire. The external flange of the tube is lassoed with the silk suture. The shaft is twisted continuously until the silk is wound snugly around the flange, similar to a dog catcher pole. This twisting action will allow the silk to grip the tube. Carefully apply sustained traction on the external flange to remove the tube safely without having to use forceps or hemostats that could potentially break the Pyrex tube.